and afar. This talk is a little more is more pragmatic than erudite, as I think most things I work on are anyway, and actually comes from a talk I gave in another form 23 times across the state of Ohio. I have never been so entirely bored with myself than giving a talk 23 times. I've repeated things a couple times. And the reason we did that, and we were one of the sites, is actually a research study I was fortunate to conduct with a faculty member at Case named Sue Flockey, who many of you know. So I'm going to talk about primary care counseling for obesity and nutrition and activity, but I'm going to contextualize it and actually give you the results of that study first. So as I mentioned last month when I was here talking about prediabetes, most people, even though obesity is highly common, have had few classes and much exposure to the pathophysiology of the disease of obesity. Most, at least in my experience, residents still are not familiar with the guidelines for the management of overweight and obesity in adults, even though there has been guidelines for this since 1999. And few physicians were formally trained to treat the obesity in their patients. Detect it, yes. Treat it, no. And fewer were actually trained to counsel patients on diet and obesity, and most importantly, how to engage and sustain in changes that support weight loss long term. And with that comes a feeling of discomfort. Physicians like feeling confident. We work really hard to have knowledge and skills, and we don't like that feeling. And that makes us feel unqualified to treat obesity and to guide people on these things. And then with all the things we have to do in practice, because these are difficult conversations and often not short conversations, we don't often know how to put them into practice. There was a recent brief research report that just came out in the Annals of Family Medicine, and I thought this was very interesting. Now, this is a survey of the general public recounting their experiences of how often they received recommended services around tobacco use, obesity, and problem drinking with screening, and if one was screened positive, of those, how many were counseled. And what you can see is physicians do pretty decently with screening around tobacco use, and counseling, and I can tell you we have a higher rate of tobacco use here, we're at about 30%, but counseling 70% of those who screen positive. You know, ostensibly, and we do a pretty decent rate of screening for obesity now that there's BMI part of medical records, and those 64 to 78% are in line with other national data. But what you can see is only about half are counseled. And what we know about obesity counseling is that even when patients recall being counseled, the number who are actually counseled according to recommendations is actually exceedingly small. So that really means more. I think 20 years ago, you know, you ought to work on that diet and exercise thing and lose some of your weight. That's really what counseling means in this questionnaire form, which we know is not highly effective. You know, for what it's worth, we talk about alcohol less than we talk about obesity, but that's recent data. And I mentioned last time a little bit about screening rates for diabetes and obesity. So what we were part of was a group and I sampled 25 primary care residencies across the state of Ohio on a grant from the CDC. So it was OBGYN, internal medicine, and family medicine. And actually, Metro was a family medicine site in the randomization and also an OBGYN site. We didn't hit the randomization for peds. And the residency sites, what we did was we went to each of the sites and we talked to the program directors and we talked to the people who knew the curriculum, and we surveyed as many senior residents as we could because we wanted them to have as much experience of residency under their belts as possible. And what we were asking them is how many of these residents felt very prepared to counsel patients on physical activity and nutrition and obesity, and this is actually from our data, and there were about 219 residents total in our mix. And what you can see is only the percentage of people who felt confident in the physical activity and nutrition was pretty small. So much more people were confident in counseling people and always counseled people on diabetes and heart disease, but only about 20% or 10% of the time did people talk about diet and activity. And the residents were about 2/3 to 75% U.S. citizens and American graduates. And what was interesting across the programs was when we looked at guidelines being formally taught, so this ONPA, if you look at the bottom of the screen, the ONPA-related didactics, you can see what we found in the curriculum was on average there were about 3 hours a year in most of the curriculums on obesity, any combination, and we were pretty generous around diabetes and cardiovascular stuff, that was dedicated towards counseling and talking to patients about obesity, physical activity, or obesity. And so that was a pretty small amount when you think of how many years. And a larger amount, 17%, were taught the guidelines about counseling, so that you should screen people for obesity, that you should offer treatment, that you should offer people with cardiovascular risk, which we'll talk about, counseling. But it's a pretty low amount, right? And so the other thing is it varies by specialty. So what we noticed is that, and I think I put that one up here, yep, that the knowledge and self-efficacy on these scales, and I'll talk about it a little bit by specialty, this is all three specialties combined, was pretty low on these items. So on the survey items we did, they have a scale of 0 to 100, with 100 being kind of your either most confident or your highest knowledge or your highest attitudes, and these were validated scales. And you could see everybody kind of falls in the middle on mean scores for knowledge, attitude, self-efficacy, and professional norms. What's interesting, though, is it did vary by specialty. Family medicine was much more confident and had more self-efficacy in the actual counseling skills and more positive attitudes towards counseling about and obesity, physical activity, and nutrition. The lowest levels were in OBGYN, and medicine fell somewhere in between. But the program-specific things, and this is why I bring this up here with a mixed audience of both learners and attendings, it did track with what the programs had. So programs that included counseling skills as well as the recommendations on physical activity, nutrition, and obesity, the residents scored significantly higher, not particularly so much on the knowledge, which was actually pretty across the board, but on the attitudes and self-efficacy, which is a higher predictor of what people will do in practice. So in summary, and it's been cited a fair amount of times, we know that still, and this is just a few years ago, that the three key primary care programs that treat adults, OBGYN, internal medicine, and family medicine, are not in high levels, at least across our state, in smaller and larger programs, teaching people about what you should be doing as far as counseling for physical activity, nutrition, and obesity screening and recommendations and counseling, and that we're not producing residents, not shockingly, with a lot of skills and confidence in that area. So the first thing, the objective of the talk was to talk about what the recommendations are. And I mentioned this last week, and these have been the recommendations since, well, I guess if you used USPSTF guidelines since 2004, is that we screen all adults annually for BMI with a height measured every couple years to make sure it's accurate for other reasons, and that we get a weight annually. And we talked last time, there's positive and negative data on the extra value of a waist circumference. But that's what we're being asked to do. And then, as I mentioned last week, patients who are overweight or obese, overweight with risks and obese, and whether or not they have cardiovascular risks, are recommended to be offered intensive lifestyle behavioral programs if they're ready to do that, with a minimum of a 6-month window with ad infinitum follow-up, as well as, depending on the situation, medication and surgical support. And then when we talk nutrition and physical activity on its own, it's a little more squishy for nutrition, and the USPSTF guidelines are actually under current review. So the most recent ones are from 2003, and this is for patients that have higher cardiovascular risk. The recommendations for patients with no cardiovascular risk factors are level C, so don't think they cause harm but aren't requiring us to do them. But in our practices, so many people have at least one cardiovascular risk factor. I think for general practice, it makes much more sense to look at this. And what it recommends, again, that word, intensive behavioral dietary counseling for adults with hyperlipidemia and other known risk factors for cardiovascular and diet-related chronic conditions. Intensive counseling can be delivered by primary care clinicians or by referral to other specialists. So again, our job is to identify and link, not necessarily do, but the linkage should be to something intensive if it's likely to engage, if possible. And then when we look at what's recommended for exercise, now these are skewed a little bit towards obesity exercise recommendations as opposed to just general recommendations for reducing cardiovascular health, because again, in our clinic, the combination of patients who are obese and overweight is 75% of adults. So in general, the CDC and the ACSM since 1993, and it's endorsed by ACOG too, recommend 30 minutes of moderate activity most or all days of the week. Since 2003, American Heart Association is 30 to 60 minutes, 4 to 6 days weekly, and resistance training 2 to 3 times weekly. Institute of Medicine, 60 days, all days of the week, and this is for weight control as well. And USPSTF 2012 included the avoiding inactivity, which we'll talk about a little bit, and being physically active on top of that for 150 minutes a week, including muscle strengthening twice weekly or more. And so what you can see is this kind of progressive piece of recognizing that when we talk about activity as a whole, it includes general activity, it includes exercise activity, it should include resistance as well. And the short answer on the primary care context is if you're looking to keep weight off as opposed to prevent weight gain or reduce cardiovascular risk, you're really moving toward that daily requirement that's really more towards an hour a day. And there's a lot of studies, including a large cohort that Dr. Arnstetter happily makes fun of me for intermittently, the National Weight Loss Registry, that shows that successful weight loss maintainers really do average the equivalent of about an hour a day of exercise in most cases to maintain a weight loss. And it's to overcome that, which we'll talk about, the resting energy expenditure depression. So these are the key recommendations. And obviously, you're not doing this at every visit. And I think that's one of the important things as a clinician to think about so you don't want to kill yourself because it's just too much. But the idea that these are things that we need to touch base on frequently and strategically and in priority come back to often really do need to be woven into practice. So talked a little bit about the training we're not doing and how, generally speaking, most graduating trainees are not comfortable, confident, or feel skilled about counseling for obesity and nutrition and physical activity, and yet over 70 to 80% of our practices, we really should be counseling about these things. And we just talked about what the recommendations were for these things. I'm going to talk a little bit about the evidence around some of these counseling activities and talk a little bit about tools after this. So the first thing to talk about is and I want to talk about this with patients too, is what lifestyle treatment and prevention are. And I think this is a really important piece because when you talk about lifestyle things, you don't want to have patients buy into the 12 weeks to a new you thing. I mean, there's very few types of things we do that have so much commercial counterbalance, right? When you're recommending something for hypertension, I'd love it if patients got on and looked at the DASH diet all the time, but generally speaking, there's not as much commercial stuff out there that's noise as well. And so part of it with lifestyle counseling is recommending that nutrition and activity aren't just for your weight, and they're not just because they're quote unquote good for you, but they underlie, and the reason I have this list here, probably a priority that fits almost every patient in front of you, right? Whether it's blood pressure, whether it's diabetes, whether it's their GERD, whether it's their asthma, whether it's their depression, whether it's their pain, whether it's the cancer they're worried about getting, whether it's their fertility they're trying to enhance. And so one of the pieces is really understanding that lifestyle counseling for obesity treatment and prevention is really woven into the greater concerns of the risks and the factors most of our patients struggle with. The second part is understanding the term weight loss when we talk to patients, again, different from commercial weight loss, and really helping them understand back to what's important to them, that 5 to 10% weight losses do really improve knee pain, do really enhance fertility, do really increase your energy, do improve blood pressure, do reduce your cardiovascular risk. So again, that framing up front on these are evidence-based achievements that have real outcomes. So, and I have a longer list in here of some of the risks associated with obesity that we want to talk to people about when we counsel them about obesity. The idea, though, and I think there's a few people here who've undergone the Teachable Moments communication process training for nicotine or obesity, but isn't to give this list to the patient. It's to think about the person in front of you and their priorities and link it to the issue that is concerning them. The other piece that's really important up front when you talk about obesity, physical activity, and nutrition counseling and the person in front of you is to help them understand the likely outcome. How many of you have had a patient who says that I'll exercise, but I don't want to do diet, or vice versa, right? That's all and I think that's okay. As long as we can get them doing better things, that's fine, but we have to set expectations around that. You know, I have a lot of people who think that if they exercise alone, it's going to highly impact their weight. Or if they just do nutrition alone, they'll be able to keep it off okay. And one of the pieces here is talking about the goal here is to lose your fat mass and increase your muscle mass, back to those original recommendations. But really, when we talk about getting on the scale most mornings, it's the diet changes that quickly affect the weight loss. It's not the exercise. On the other hand, when you talk essentially preserving your investment, it's really the exercise that preserves weight loss and lean mass. And so that's a really big deal. And lastly, which is a very big deal, and I had 2 patients this week actually 3 that I thought were very illustrative of this. Life events really affect the system and can cause significant changes in distress to patients. Women going through menopause, doing everything the same, will gain weight because without estrogen, they're not preserving their muscle at the same rate, and so they'll be gaining some weight doing everything the same in many cases, and that can be more or less in some families. Similarly, I've had several nurses here go from floor nurse jobs to call center jobs, and I can safely say that intervention gets most people more than it costs to quit smoking. It's usually a 15 to 20 pound gain. Most of my floor nurses will wear pedometers, and I can tell you that's an 8,000 to 12,000 step a day enterprise, and we sit them down, and it's a whole other gig. So, you know, all these pieces mean that this isn't just something we have to address. We have to address with changing context across time, because otherwise patients feel failed and demoralized. They think it's their fault, when really the game just gets tougher, and it's our job to help them be strategic and hopeful. The other piece, which sounds dumb, but we actually have to explicitly let them know that diet and activity improve their health outcomes as well. And the last thing I'm going to say here, which is kind of this piece of what this medicine can do as a whole as we get into the individual medicines, but I tried to do obesity first because it covers the whole enchilada, which is when we talk behaviorally reasonable goals, and there are, you know, people who can do more, but it's roughly 1 in 1,000 people or less who can go from severe obesity to normal weight and sustain it. So if you start out with a BMI of 40 or more, the likelihood that you can sustain that long term into anything 25 or under is less than 1 in 1,000. So when we talk averages, obviously we're not going to argue if somebody can lose 20% of their weight and keep it off with behavior alone. Nobody's ever yelled at me for losing too much weight. However, when you're trying to set goals with the person in front of you in that range, I give them numbers. You know, if I have a 250-pound person in front of me and they say, what am I likely to get from diet and exercise as my first step, because that's what we're going to do first intensively, you know, I say, you know, if you're 250 pounds, we're going to shoot for 25 pounds. You might get half that, you might get half again that, and we'll see how hard it is and what combination of things get you there. But that's our range, and that is often sustainable long-term with work. But the piece with this, and this is the program components, that level of weight loss takes all 4 components. Nobody sustains that kind of weight loss long-term with just diet changes, just exercise changes, just a few coping skills, or just following the numbers. It's some level of all 4. Some people have it a little easier, some people have it a little harder. We'll talk about that. But while you're not doing it at one visit, you should be aware that those components need to be either systematized or monitored so that they can make a system that works achievably over time, which is why when we talk about commercial programs, if they're not affordable long-term, they're not going to give you the result. So why don't we do short-term results? And this was kind of when I entered this field of interest in the late 90s, is if you do 12 weeks to a new you with behavior alone, patients overwhelmingly regain the weight. And basically, behavior therapy, which really means coping skills and system skills, and exercise are the key to keeping it off. You can't just change your behavior short-term, because I'm going to throw it to our residents here. Most of our residents are praying that their lives look very different in 5 years than they look right now, right? So whatever diet and exercise schedule you have right now ain't going to fit in 5 years. So telling you what to do isn't very helpful. Telling you what the goal is and showing you over time different ways to achieve it under multiple circumstances is the key to this whole thing. And if you've done any of the studies on willpower and self-regulation, which show us that you may have as much character at 8 a.m. as 8 p.m., but your ability to resist pizza in the report room that the nurses bring in is very different with the beginning of a 12-hour shift and the end of a 12-hour shift. So those are systems issues. So when you talk about changes over time, we've really got to help people understand those components. This is one of the most intensive behavior studies that was ever done. Tom Wadden was one of the PIs on this out of Philadelphia. This was the Lookahead Trial. And it was basically an intensive weight loss trial that was done over, it was scheduled to go, I think, for 7 years. They stopped it at year 5. It was done in diabetics to prevent primary cardiac events. They stopped it early because the groups weren't separating, but there was actually a lot of weight loss information in this that we didn't have before. And what these shows, and these are nested essentially because everybody in the first column over to the left is in the column over to the right. But what this goes, and it goes by different BMI class, is it tells you the number of participants from each BMI class that lost 5%. We said that's that threshold for clinically meaningful weight loss, to 7%, which is kind of the goal we set for diabetes prevention program, or 10%, which is extra good. And what you can see in significance is that the bars to the right, the class 2 and 3 obesity, or moderate and severe obesity, had higher proportions of people who lost greater than 7% of their weight and 10% of their weight. And what that says, which I think is important, especially because we know, especially in the overweight category, if people are improving their eating and activity, even maintaining weight may be okay as far as morbidity and mortality go, as long as your knees can get along with that. But at those higher weight losses, it was the higher BMIs that actually had more benefit. And so that's actually a reassuring factor from Lookahead. So again, and it was a heavily diet-related program. We'll talk a little bit about the tool of meal replacements. And one of the things Lookahead did was people who chose it could use meal replacements long term. So bars, cans, boxes, essentially, models. And it was the largest longitudinal trial that had that in it as well. And if you look at the sub-analyses in the groups, some of the groups who did best with weight sustainment were the people who kept using the box or the bar or the can. And we'll talk a little bit about the role of those things as well. The segue into that, into real life, because that's a study, is how does this translate into commercial programs? And the difficulty is honestly cost and practicality. Anybody had a patient who's done Jenny Craig, Nutrisystems? Not too many. So you don't see it as much at Metro. Because I've been odd practice, because we select for those folks, have folks who've done both. Physicians, weight loss centers a little bit as well. And basically what you're paying for are a few doctor's visits and a lot of food, basically. They make a lot on giving people, and Weight Watchers has some of this product too, but a lot of cans and bars and frozen boxes and that kind of stuff. And the thing that's important about it, and I'll talk about the components of more available stuff, is they can work, and actually some studies have been done. I'm trying to think of what the name in England, but Weight Watchers has been looked at too, which we do here, and that one's a lot less food prepared oriented. Jenny Craig's been looked at, and there's an English one in Great Britain that's kind of like Jenny Craig, and I can't remember the name of it, that is here too. That's the Lighten Up trial that was published in BMC in 2010, but it's very similar to Jenny Craig. And they have shown to be superior to basically work on your own. And the reason actually ends up being a lot of the ways they systematize things. So if you've had people, now you guys have had people who've done Weight Watchers, if you have employee patients, do you have somebody, yeah, so that's more. And so we as a system actually reimburse for Weight Watchers as well. And the reason I have advocated for that is it has multiple ways you can choose to approach the diet in Weight Watchers. It has weekly weigh-in, so it's got the monitoring. It has weekly adjustments. Based on that data, you adjust your points or you adjust your portions, depending on what you're doing. So it's got that response to data when we talked about the components. And again, when you talk about changing the scale, it matters. And it's got plans for lifelong things. I had a patient who I've seen here who hit lifelong with Weight Watchers. I forget how long it is. And then they give you free membership after that. But if people can afford it, it is a sustainable long-term option. It also has online stuff. The other ones really are very, very expensive. But they at least, kind of like Lookahead, gave some credence to this combination of weigh-in and other stuff. As far as diets in general, Healthy Plate volumetrics, oddly, and Mediterranean diet have been some of the ones shown to be most helpful around weight itself. And lastly, on the diet end, because it's a little more people achieve in lower calorie levels differently, I just want to mention a little bit about macronutrients because I get asked a lot about it. And really it has to do a lot with the long-term macronutrients because short-term before your ghrelin levels rise, you can do a lot and not be starving, but somewhere between 2 and 5 weeks after you go into a calorie reduction, you know, your hunger hormone, the ghrelin levels rise and stay peaked for a long time so that you want to eat your arm. And so the question is, what types of eating are more likely to sustain fullness and satisfaction and help reduce hunger? And what they did in this trial, which was kind of nice, and you don't see these very often, is they actually had a bunch of people lose weight in a short-term piece. It was 3 or 4 months. And so everybody starts out, that's why there's a 0 at the right-hand side. So they all start out at the same point because it's their weight loss at the end of the trial, and they all had to lose, I believe it was at least 10% to get into this, so they'd all lost weight. And what they did is they randomized the folks into basically 4 groups and a control. And the control was just basically told to eat a diet within calorie control of whatever that last weight was. And then the rest of the folks had an isocaloric diet that differed only in its macronutrients. And so you can see where the control line is. It's that yellow line that kind of pitches upward like we would expect at the end of a behavioral program with no follow-up. And the LPHDI is low protein, high glycemic index. Now that actually is pretty close to a typical American diet. So these guys were specifically put on that diet, and you can see they track pretty nicely with the controls. The orange group then was a high protein but high glycemic index diet. So they could have white bread, but they had more chicken, fish, and eggs than the other group. It was typical. And you can see they regained, but at about half the rate. The low protein, low glycemic index group was given a lot more vegetables and whole grains when they had grains. And they tracked really with that high protein, high glycemic index group. But that bottom one, which I would love to see the follow-up study for, I have not seen that follow-up yet, but what you can see is at least for about a half year, with a high protein, low glycemic index diet, and it really was much more in the vegetable range than in grains, they were able to keep it off better. And again, I'm not interested in short-term weight loss. It doesn't really help the disease any more than I think any of you are interested in short-term blood pressure control. But when we talk about diet counseling at the end of it, I think it's important, even though the evidence isn't fully in on some of these things, to really move people towards the healthy plate, which is half vegetables, low glycemic index, right? A quarter protein or more, you can increase that wedge, and the carb quarter better be a pretty nice looking carb quarter with more complex carbohydrates and fewer simple sugars. And I think these two things go together, so they're starting to align. What that ends up translating into are the calorie guidelines that have been out for the last 18 years. The problem is that even by nutritionists, calorie counting is woefully inaccurate. It works a little better with Weight Watchers points, but most people are unable, due to a variety of factors, to end up there. But when you actually look at what people who sustain weight loss do, this is about what it ends up being. I'm not going to go through these because I want to get to the other pieces, but I will tell you, just because, again, it's nice to start to see things align. Prudent dietary recommendations for cardiovascular risk factors really look like a lot of this in the Mediterranean diet. Those have been out since 2008, and they're in there. And so I think the take-homes are that low-calorie diets are better than, and I will mention the very low-calorie diets. Those are the ones where you go to a medical place and you do the shakes and protein-sparing fast stuff. There is some evidence if you've got, and remember that's a very highly selective group because it's a high socioeconomic status in general. But in general, there's not much improvement for all the changes, and they don't really teach you lifelong work. Meal replacements are useful, and this is what I wanted to get at is, and Lookahead really showed that. And it's not really about the brand. It's more about if you're going to do pickup food, nobody's ever saying, please don't make fish and salad and cook for yourself. You know, the issue is, are they stopping at McDonald's or are they picking up a lean cuisine? Those are my options, right? So the question is which pickup food, not if pickup food in most cases. And if that's the case, back to that other piece, you want to do a combination of high protein and low glycemic index. So, I have people who will do a bar and a salad. Works pretty well. I have other folks who will do, a lean cuisine and some extra protein on the side. It doesn't matter, but the point is they're a good tool for people who are going to pick up either way. So, again, if I had a personal nutritionist and cook, I would, God bless, use it every day, but sometimes I got to pick up food. And the other piece is make sure, that they're lower sugar, because a lot of the shakes and bars can be higher sugar. One last word that's been shown recently is shakes are not as efficacious, particularly in bariatric patients, as bars. They drain too fast, and they're about an hour short of the fullness mark compared to bars on average. So like most things, chew your calories, don't drink your calories. Back to diet recommendations. When we talk cardiovascular, we're going to talk in a way that really is consistent with the cardiovascular diet, but people have to eat what they like, so that we're having low glycemic index foods with lots of produce and healthy proteins, but they have to be achieved with plans where people don't need to count, they can't do it anyway, where they can do it even when they're at a family reunion, even when they're traveling, even over Christmas, even when they're working extra shifts. And we have to encourage them to use low or no cost supports for tracking and things like that to keep track of things. And of course, exercise, we have other tracking options. So that's kind of it on the tools around diet. Obviously, you guys know in the total energy intake, we have physical activity next. Let me grab my phone because I don't have a watch, I apologize. I want to make sure I'm balancing. There we go. Okay, we're at 42. We talked earlier about aerobic exercise, and aerobic exercise, and Juan Pablo's here, you have to be a lot more regular about exercise if you're on insulin, because we've got to keep things a little more steady Freddy. But if you're not on hypoglycemic drugs day to day, you can adjust for weekend warrior if you need to get some rather than none. But ideally for weight control, you really want aerobic exercise to be on and off at least through the week as opposed to just on the weekends. And it's actually because of the buy one, get one effect. So when you exercise on that day, you have the calorie burn of the aerobic activity that day, but you also, and our cardiovascular friends probably know better than I, but you also have an increased resting energy expenditure for somewhere between 16 and 24 hours following that activity. And so again, keeping your resting energy expenditure higher through the week as you're trying to keep your calories even is a little more effective if you can at least go every other day. Again, we do what we can. There's ideal and there's practical, but it's there. I have to take everything else from my patients. I'm not taking my caffeine supplements, but it's why I don't take coffee and TOA. I will just point that out. Resistance work over time is really critical, and it's particularly critical in women who have to be told all the time that you will not look like a linebacker if you lift 10-pound dumbbells. Can't be done. But I still get that a lot. But resistance work over time increases and preserves lean mass and raises resting energy expenditure because muscle has a much higher resting energy expenditure than fat. I actually tell people this because one of the things that they talk about is they talk about slowing metabolism with aging as an inevitability. And there's actually some nice geriatric studies that show there's very little reduction in energy expenditure that is attributable simply to aging. Most of it's attributable to body composition changes. I kid you not, I have an 80-year-old in my practice who is running triathlons. I can't even believe her. She's quite ridiculous. And does substantial lifting. And I am guessing her body composition is way better than mine on any day of the week. So in watching this, one of the pieces is I help people understand what the machine is and how it relates to calories so they understand why to do it, especially because most people have not done this before and it's a little weird. So I start with where people are at, but it is important to talk about this as the destination. We get them, start with that and we move them towards it. But that is really an important part, particularly when we talk about glycemic sensitivity and weight overall is the increasing need to recommend resistance. And you saw several of the recommendations really do recommend it now. What's really important is, and this is where life gets really unfair, when you lose weight, and actually, oddly enough, it was the biggest loser study that got us to the 6-year mark. Bariatric studies are showing it as well, though. Even 5 to 10 years after a substantial weight loss, you have a sustained reduction in your resting energy expenditure that does not improve. Now, Most people on average have that resting energy expenditure reduction in the 10 to 20% range, which means if you weighed 250 pounds and now you weigh 200 pounds, your calorie balance isn't the calorie balance of somebody who weighs 200 pounds and never was more. It's going to be somewhere between 10% to 20% less than somebody who was always that weight. The problem hereditarily, and this is the varied results with the patients in front of you, is that for some people, it can be up to 40% less. So when people say, I'm not eating anything and I'm still not losing, they're often telling me cruise. And I will say, ethnically speaking, it finally explained what was assumed to be adherence problems in African American women, who tend to be some of the ones who have the highest reduction in resting energy expenditure as a group. So that's not all. There are some African American women who don't have that, and some Caucasian and other groups who do, but as a prevalence issue, it seems to be more prevalent in that group. Excuse me. This is a big deal for variability of results, and it's why different people need different doses of exercise and different calorie balances at the end of it. So I think it's important to understand that when you start with a patient, you cannot predict the results, and it's why different people may need extra things as far as medication and surgery as well to really maintain results. So when we talk, as I mentioned before, about exercise and body composition, we already mentioned the calorie output from aerobic. It was the fit and fat and cardiovascular disease look. We get asked a lot about this, and you can see these are hazard ratios for men and women who are fit and unfit at different BMIs and their hazard ratios. And you can see that when the BMI goes up, there is a little bit more risk, but it's not as much for the fit women at higher BMIs as it is for the unfit women at lower BMIs, right? So this is that whole fit-fat piece that came out about, originally, I think this was one of the more important articles, about 16 years ago. The difficulty with this is a snapshot, I will tell you, especially because I don't see many people with BMIs of 27, I see more at 37, and I see some very fit people at BMIs of 37, I might add, is the difficulty with that isn't so much in the overweight range, it's in the obese range, where the weight load on the hips, ankles, and knees makes sustaining fit and fat not practical. They just can't do it, because after a while the wear and tear in the joints doesn't help that. So in this, which is the really more at a lower average BMI, I forget what the average BMI was, it was greater than 28, but I think the average was like 32. It doesn't really deal with the fact that this was a snapshot in time and kind of some risk factors going forward in mortality. That really, when you look at function and pain and disability, it really starts to break down with age pretty quickly. The other piece, and this is I have a lot of people who are reluctant to exercise, and so I just mentioned this, is if we have to talk about controlling blood pressure, stopping people from smoking, improving their diet, basically, if we could do one thing, physical activity is the most important intervention we can do to improve cardiovascular risk, and I might add it helps a whole lot of other things too. So I just bring that up, even more than smoking. I'm going to move ahead a little bit. I did mention the recommendations. What I come away with on the recommendations from a primary care sense is move most days of the week. Try to do 60 minutes if you can't go fast. If you can go faster, do 30 minutes. Try to lift weights. There's a guy named Jim Hill who's done a lot of work around weightlifting. He's very funny, and he's done a lot of erudite work. And basically, if you can get people to lift weights once a week, you won't go backwards as fast. If you get them to lift twice a week, they'll hold. If you get them to work 3 times a week, they'll improve. Is kind of how he was summing up his years and years of work, chuckling that it really just seemed to come down to that. But that's become easier as a lot of these places have circuits for training, like curve circuits and things like that, even though Curves is no longer in business. So it's, God bless Planet Fitness, $12 a month. Gyms have become way more accessible than they were just a year ago as they spread up like little purple flowers everywhere, so it's a great thing. So how are you as a prescription? So prescribing exercise, even more than nutrition changes, and we did this actually at Metro too with some short stuff, has been shown to be pretty darn effective. Turns out you have a half-life of roughly 6 months. You don't cause constipation or headaches usually, and you will see improved activity. So we know that brief counseling to improve activity statistically improves people's actual activity for, on average, about 6 months. And we see most people about twice a year, so it's not a bad deal. I bring up the durability, teasing aside, as an important piece because we know for intensive weight loss, it's that frequency, the dose of the people that matters. You are one of the interventions. And the more often you can both prioritize and reemphasize and link it to the other values a patient has, we know that that is likely to increase sustainability and progress. I have some slides in here about things people can do if they're kind of ambivalent. You can reduce your TV time. You can, do Dance, whatever that video game is. What is it called? Yeah, with your kids. I've done that. I'm a complete dork. Well, I was a dork beforehand, but but there's all sorts of fun things you can do. But actually just giving people permission to play again is often very good. And really understanding there's some people who exercise and some people who will play, and really kind of figuring out the two. Some people need buddies. Walk it off, talk it off works for a lot of people. I had a few women who used to go after they dropped their kids off for school. They called it the B&M Club, the Blank and Moan Club, and they got a lot of mileage in. So there's all sorts of ways to get creative, but a lot of times it's that brainstorming piece and really kind of continually reassessing readiness. We talked about this last time. Readiness isn't motivation. It's the ability to engage. If they're in huge pain, if the depression's acting up, if they have sleep apnea that's not addressed, we've got to get them medically ready and not just psychologically ready. And as I've mentioned, linking things to their values and motivators. People do things when it's important to them. And so really helping a woman who's responsible for everybody else understand that self-concern is part of her responsibilities, and awareness and honesty are keys to making and adapting plans are really powerful pieces to work with. We do that in our STRIDES program, and that is the thing we hear back on feedback most of all is, I realized I needed to be on my list. If I'm going to do the things that are important to my family, I've got to be taking care of me and not feeling guilty about that. And again, we see majority of women patients here. It's a really big deal. This is often the thing that is hurting the responsible adults who are taking care of everybody else in our practices. So again, counseling about obesity, physical activity, and nutrition really needs all four components if you're going to lead to weight loss, and in most of the cases, that's really what we're looking to achieve is some modest weight loss, improved healthy eating over time, physical activity, and enough monitoring to keep us consistent and prevent progression, right? That's the components. I just bring a few things just with people who are talking things through with you. And again, I put a lot of these in here to look at things, but these have to fit people's values and preferences and resources and finances, and we have people to refer to. Before I end here, I want to just circle back to remind you guys just from last time, people really want us to talk about this. So we talked about at the beginning, people aren't counseled all that much, but people really want to be talked to about their weight, about eating, and about activity. They just want us to be respectful and help them move forward and problem solve and not be judged. And we know clinicians actually who do this have better, back to those patient satisfaction scores, get better patient satisfaction scores and engagements with their patients because patients feel listened to, they feel respected. When I have patients, residents rotate through my clinic, I'll have a social conversation and I'll say, what did I just learn? And I learned their sleep habits, their work habits, their nutrition habits, their financial stressors, and that. It looked like I was just sharing. And it really helps people feel connected with. And you're really applying knowledge at all those points. The last thing I want to put in here real quick, I re-put in the DPP stuff. If you remember, the DPP and STRIDES pieces are our intensive parts. But as far as how to begin, some people we've got Teachable Moments, we've taught people, there's 5 A's, but the point here is, other than being patient-centered, respectful, and following up, there is still no one proven method. We are going to, and this is a face forward, we have some tools in for folks who've learned the Teachable Moments around tobacco here, and we're going to be doing some around weight in the next year. So look for those to come. But right now, just know any patient-centered technique that starts with a goal, is respectful to the patient, and follows up is helpful. And you can use that goal-setting part in EPIC now to do that. And remember to help patients know that it really does work. And the last part I just wanted to point out is the resources here. Make sure you're getting the sleep studies. Make sure they're going to the obesity clinic if needed. And nutrition or our clinic as well. We now have a lot of common resources to help people have some literacy-friendly things to do those. If you need handouts for your practices, the Weight Management center and the nutritionists have spent the last 2 years developing handouts on these things. Let us know, and we'll get them for you guys to hand out to folks. So with that, I'm going to stop, and am I allowed to take questions? And take any questions on what might be useful to anybody for whatever. Thank you.
Very relevant. Question, we get a lot of menopausal women.
Yes.
Can you talk a little bit about any specific strategies for menopausal women? I think in the past we've gone with, strength, resistance, training, whatnot. And then are they increasing over time? And then if they're reducing their caloric intake, like how are they going to maintain all that?
So the question is, how do we deal with women in the perimenopausal, postmenopausal period who are coming in and struggling with this? I think there's 3 issues that are really key here. The first one, which comes upstream from the weight, is to recognize some substantial increased risks that happen in the perimenopausal period that may prevent engagement. The risk for depression, anxiety, and sleep apnea, even without weight gain, increases hugely. And I didn't know it about sleep apnea because I thought it was driven by the weight gain. It's not. It's the loss of estrogen shown. It's like a 4 to 5 times increase. We have one of our pulmonary folks in here, but it's a much higher increase in sleep apnea in those years after, because I have a lot of women getting tired, and I thought it was the sleep interruption, and I've had a lot of people with pretty normal BMIs newly diagnosed with sleep apnea. So I bring that up first because I think as the clinician, our first job is to look at what might be getting in the way before the behavior engagement or with it. The next piece with that, and this is the menopause piece, and I think we're going to probably see over time some reconnection with using hormones, and I'm going to let our OBGYN friends deal with that. I think that is a good thing to revisit in some cases. However, aerobic exercise really helps with mood changes, anxiety, sleep disruption, and mood and depression too. So that's one of the places I start with them, is if I can get them to do anything, I start them moving. Food is tougher, and I often, it depends on where they're at on the BMI scale and where their readiness is, but I do really push not so much calories, it depends on what they're coming to me for, but in the primary care setting, eating for fullness. And if I can't get them to say, I'm going to give up something, do what we do here, which is eat the vegetable half and the protein part of the plate first, because then you won't feel deprived that you're not going to get the carbohydrates. But when you start with the other ones, you won't eat as many of the carbohydrates. And really try and avoid the foods that are going to start the reward cycle going, simple carbohydrates and sugars. So I really do a lot of good general eating, prioritized eating, get that protein in the morning, and get the exercise in. Weight is a big deal. And what scared me is, do you guys all remember that bone density loss that starts with menopause and then reflattens out 5 years after? The scary part is the sarcopenic one starts going down in parallel with the bones, but it doesn't stop like the bones do. And so to me, I really work with women in their mid-40s trying to do 5 years prior to really get them to start lifting at least once a week. But I have a lot of women, I have women in their 80s who still do essentially the curved circuits now at the other places. I really try and get them into either a body sculpting class once a week or into one of the gyms where you can get the circuits and go with a trainer a couple times to just do that, or get somebody who knows. It's simpler than you think, and those 2 things help with mood, insulin resistance, and loss of muscle. So if I can even get them to commit to weekly. So depending on order, I prioritize, let's introduce you to weights, let's getting your heart rate up so you don't kill yourself or anybody else, and prioritize eating. Does that help? Yeah. Okay. Other questions? Yep.
So with the reduction in the resting energy expenditure that comes with weight loss, is there a way is that driven by muscle wasting? Is there a way to mitigate it with muscle building?
So this is a great question. I'm going to repeat it because I think it's not on the microphone otherwise. So the question is, with the weight loss, reduction in resting energy expenditure, is that driven by loss of muscle, or is it something else, basically, right? So it is not just driven by loss of muscle. So when people lose weight without exercising, they will lose more muscle than they will lose if they're not exercising, but you always lose some muscle. So there's always some muscle loss. But the quality of the muscle fibers, as well as the total muscle mass over time, are not the reason for the reduction in resting energy expenditure. Even if you do all those things, you still observe a reduction in resting energy expenditure. It's what they used to call that set point theory. But again, there's this memory, and we're not sure mechanistically. There's a few theories on it, and there's some work that shows that some of it is at least driven by the adipose cells themselves, but that it persists. Like I said, we have data now definitively up to 6 years, and there's some bariatric data that looks like longer. Because even folks who have bariatric surgery, they don't lose any fat cells. They just shrink as best we know. So that change, that sense that there's empty file cabinets, essentially seems to persist. I don't know another kind of graphic way to explain it. And it seems to have some individual variation. So all you can do is raise the resting energy expenditure by optimizing lean mass versus fat mass. One more and then should I stop?
I'm hearing of more people doing fasting 3 days a week.
Yeah, I'm watching that one. I was just at the Obesity Society. There's some studies that show for some people it may be helpful. I got to tell you, though, I have not seen fabulous results with it. I've seen it undo a lot of routines for a lot of people because they can't, special occasions happen and then things come up, and it ends up being that the fasting days don't end up so fasting and the overeating days seem to be more often, and I'm watching that one. That's all I'm going to say about that. Next year. All right, thank you very much. Anybody who has any questions, I'm happy to answer afterwards, and I will send the PDF, which again has some referencey ones there, and happy to answer questions by email too. Thank you. Do I just log off of this?
I actually don't.
No, I was going to say I thought you have to do that.
I have to do some clickety.